I'm very happy to be here. I want to thank Angela again for inviting me to have this conversation with you. Um, and I am going to try and structure this as a conversation. So I'm going to do maybe at most 30 minutes of slides, maybe even a little less than that, and then open up to what you want to talk about. I have more slides prepared in case we touch on questions I think you might have you might ask, or we may go in areas where I don't have slides, in which case we'll just have a conversation. So that should hopefully be fun. So thanks again to the University City Science Center for hosting the Venture Cafe and inviting me. And I also, before I even introduce myself, want to thank two of my colleagues at LaSalle University, Dr. Kelly Daly in communication and Dr. Kristen Rexing in public health. I've had the good fortune of working with both of them in the last year on vaccine and COVID stuff. And as we've learned with COVID, a very complex problem requires interdisciplinary solutions. And I've learned a lot from the communication and public health side that's really helped me kind of be more informed. And so a lot of this presentation is informed by work that I've done with them. So I'm just really grateful for their expertise. And again, before I even talk about who I am, which I will do in just a moment, I want us to take a moment and just consider who are we in this space together. So I want to consider not just who you are, and who you are might be, your ethnic or racial background. It could be the type of work you choose to do. It could be the type of, hobbies or other things that you do, the type of communities that you belong to, perhaps a faith that you follow or ascribe to. But it's also your experiences. And then I want you to think about who is with us in this room together. And what are their experiences? What are their communities? And what are they bringing to this space together? And I invite us to just consider that, because for something like asking whether, as I posed maybe a little provocatively, whether vaccination is a civic duty, I think it's important that we consider our own experiences and where we're coming from, as well as other people's experiences and where they're coming from, because a community problem requires really a community effort. And I want to make sure that we're always framing our conversations and our thoughts to be inclusive of both ourselves and others, and to therefore be curious of what other people are experiencing and coming to the space with. So this is what I'm coming to the space with. My name is Jason. I have a PhD in cell molecular biology, and my PhD work was really with virology, with tumor viruses at the University of Pennsylvania. The work that I do is I'm a science educator. I am an assistant professor at LaSalle University, where I teach biotechnology classes, which can include vaccine design. And so that's my interaction with science. But what I bring to my science, to my education, and to this space is also that I'm part of an immigrant family. And so I have a particular both personal and just more extended family life experience with the world that might be different from yours. And I'm also a gay person, and especially with respect to COVID and thinking about protection and surveillance and things like that for viral infections, my experience with HIV as a gay person is and the threat or concern of HIV has also really dramatically informed how I think about COVID and protection against COVID and surveillance and things like that. Those are just some parts about me that I'm going to share that I think are going to inform my perspective today. So I title the talk, is vaccination a civic duty? Just to kind of frame a little bit of a conversation to get us thinking about our role as community members, not just to protect ourselves, but to protect others. To really address that, though, we need to really consider that people are going to be coming to the question of vaccination with different experiences, expectations, fears, and information. And so we talked a lot about vaccine hesitancy, and there are lots of reasons why people might be hesitant for vaccines in general, and with the COVID vaccine in particular. Individuals may have lack of trust in the system because of their personal experience or from the experience of others that they are familiar with. Individuals may have misconceptions around vaccines or not have the information they need to really kind of assess the cost and benefits of vaccines in a robust way. There's been plenty of historical abuses by the medical system against particular populations of people, and that has really eroded trust in the system for many populations. And then for COVID in particular, there is still, I think, a lot of debate at the national level about how serious we should be treating COVID and whether something like a vaccine is really necessary. So that's going to be, these are just some reasons why people might be hesitant. But I don't want to also take away from the fact that there are plenty of people who are very excited about the vaccines, myself included. And we might be excited because we're excited by what the data tells us these vaccines can do. We might be excited by the fact that these are new vaccine technologies that are finally getting a national spotlight and may influence further development of new vaccine technologies. We may be excited by that this is an opportunity for us to do something not just for ourselves but for our community, because vaccination and forming that immunity does contribute to herd immunity, this community immunity, and this is one way that we can finally be acting in direct solidarity with one another. And others may just, I just personally also am tired of lockdowns. As much as I support many of the interventions that have been put in place, and we can talk about that if you would like, I am tired of, I would rather be here in person with you and be able to see you and really be in physical community with you. And we're not doing that for safety reasons. And I would love to be able to do this conversation with you again in person. And vaccines are one way that we can kind of finally get there. And so if this is a conversation that you find yourself having with many other people and you're not quite sure how to navigate this conversation, I would encourage you, and this is again based off of expertise from people who do persuasion and communication and empathy a lot, that you really approach these conversations from a standpoint of compassion, empathy, and that the goal should not be to confront someone, but to understand their perspective, and then to help them understand your perspective, and see what grows out of that dialogue, right? And that's how I'm going to be hopefully framing whatever conversations we have when we get to the conversation portion in about 20 minutes or so. And so one way you can do that is just to basically frame your conversation as be curious. And that's why we're going to spend so much time today, me asking you, what do you want to know? What are your concerns? And you might ask, what information do you trust? Because we are in a situation where there's a lot of conversations just even about what media we should trust, what are facts, right? And as a science educator, that is a bit challenging for me that we are in that moment, but this is where we are, right? And so having a conversation about what kind of information do we find persuasive? Why do we find that or that information persuasive? I think that could be, one area that you might just, open things up and explain why you trust some sources versus others and why you value some information versus others. And I just have on the slide, what I value, right? I do believe currently that the FDA and CDC are doing their best to give timely information. Dr. Fauci has had a very good, consistent record, in my opinion, of like giving us the information as accurately as possible. Especially, I think more recently he's felt a little bit more open to kind of to speak honestly on these topics. And we can talk about that, about whether you might agree or disagree with me. You might ask someone, if they have a different perspective on vaccination, what information or what data would you want to see that would make you feel more on board, for example, with getting vaccinated, right? And so some people are concerned about safety. That's usually a big concern. Some people are concerned, does it actually work? Is it actually worth the possible risks that are involved with vaccination? Lots of conversations about do I feel like the research was done ethically and robustly? And again, do I believe that COVID is important and serious? And then that conversation about cost benefit analysis. And actually, this is an area where I think a lot of people really could benefit from having conversations with others, because the way that I frame the cost benefit for me may be a framework that you had never even considered, and might actually make you think a little bit differently about your approach to vaccination, and vice versa, because we all have different experiences and things that we're bringing to the conversation. So I'm hoping that by now, so having said that, one of my goals is actually to convince you that I believe that the current vaccines are great, and that I would hope that as many people as possible will take the vaccine. And so I'm going to just go through kind of what my perspective is on those, and then we'll kind of see what your questions, concerns, or even pushback might be, right? And so, in my opinion, or not my opinion, but based on my understanding of the science, right? I think we can say pretty confidently at this point that COVID really is worse than the flu. And this is actually an infographic from early, like I think May last year. So we've actually learned a lot more since then, and this still has pretty much stayed true. Where COVID is more infectious than the flu, COVID has a longer incubation time, which means that it can actually spread farther because people are still infectious when they're not symptomatic. The hospitalization rate has fluctuated as we've learned how to better treat and catch COVID early on, but it's still much higher than influenza hospitalization rate. And the case fatality rate, again, has fluctuated as we've learned how to better treat. But again, that's still way higher than it is for influenza. And we know that this affects people differently depending on who you are. So we know from a biological standpoint, one of the key risk factors, biologically speaking, is how old you are, because how old you are has something to do with how strong your immune system is. And still to this day, those of us who are on the older kind of decades of our life are definitely more at risk for very serious disease and hospitalization. There are various comorbidities, so other disease states or conditions that you might have that put you at higher risk for COVID illness because of the interaction between what COVID does to your body and these other conditions like cardiovascular disease, diabetes, chronic respiratory disease. And we know that for some communities, especially communities of color often have a much higher incidence of these comorbidities. And it's not because biologically these communities are more at risk, but rather what we say in public health, the social determinants of health. So this is the idea that if you don't have access to good housing, if you don't have access to robust medical services, if you don't have access to ready supplies of good, healthy food, you're going to be more at risk for diseases. And so the communities who are already at risk for these other diseases because of these social determinants are now also at greater risk of COVID disease. And we've seen that borne out as early as, March and April, all through today, that communities of color repeatedly are more at risk for serious COVID disease because of these kind of structural inequities that exist in our country. And similar to that, we actually even know, just if you just ask what is the income of the person who gets sick, people with more money and more income available to them do better, because this is oftentimes, we can treat this as a proxy for the type of healthcare they have access to, the type of services they have access to, et cetera. So everything's kind of interconnected there. So COVID is a serious disease. And in this country, we place a lot of emphasis on individual responsibility. We are responsible for addressing challenges in our life and finding the resources and the wherewithal to kind of get through issues, pull ourselves up by our bootstraps type thing. This is a key component of, I think, American culture, that different people interact with it in different ways. And because of that, the question of what can I do to actually help others, is treated a little bit differently in this country than maybe in other cultures that are more collectivist in approach. And that's not me saying one way is better than another. It's just this is kind of the framework that our country is kind of entering this problem with, right? And so when we think about COVID, there are several mitigation strategies, and some of these are to help us and some of these are to help others. So for example, wearing a mask, right? The primary function of wearing a mask is actually to help prevent you spreading your disease to others. It does somewhat help you prevent you from getting infected from others, but it's actually primarily to help contain any contagion on yourself. And physically distancing is for protecting both myself and others. And we have things that are more about, obviously checking our own conditions, right? But then we have things like quarantine isolation, which is again to protect others. So there's this constant kind of tension between mitigation strategies you might use to keep yourself protected and those that we use to keep the community protected. And the reason why we are interested in the community is we know that different people in the community are going to be susceptible to different degrees, and there are real things that we can do to make sure that those other community members are not affected. And I think a very powerful way of thinking about these mitigation strategies is a Swiss cheese model, right? And the model here is that any particular intervention is not going to be 100%. So there's a lot of like concern about, well, masks aren't going to 100% protect you from COVID, so why should I bother even wearing them? And the answer is that it still makes a difference. Yes, it's not 100%, but if you combine masking with social distancing, with washing your hands, with isolating and quarantining yourself if you feel sick, if you combine all of those different methods together, any little holes in each of those methods will be potentially covered by others, because there's no necessarily reason why one mitigation strategy's weakness is going to be the same as another's. And so if we can stack these different mitigation strategies together, we can actually make a very robust strategy for preventing COVID disease. And I'll just note here in this infographic, the last slice of cheese is vaccines. Although I would say the vaccine, not every mitigation strategy has the same power. So I would say vaccines may be even more powerful than some of the other interventions that we've had. And there are many other situations actually where we take advantage of the fact that multiple small safety features result in a net, much safer experience. So if you think about why do people still obviously get into serious car accidents. I mean, Tiger Woods was just featured recently as being in a serious car accident. Why is he, he's still recovering and is in serious, in serious recovery there, but he didn't die from that car accident. Why is that? It's because over the years, we have steadily built more and more safety features that individually are not going to protect you from death if you get into a car accident, but together really increase the safety profile for driving and make it so that we can go out and drive and we're not necessarily always worried that we're going to die in a car crash. Obviously, we're going to be concerned about we might be safe on the road, but we still go out and do it, right? And I want to also note that when we think about driving, it's not just the technology of the car that is acting as an intervention, it's also the behavior, right? Why do we have rules of the road? It's so that we have a common understanding of how we're going to interact with each other on the road in a way so that we can navigate those road spaces safely, and we understand, who's going to get the right of way, how we're going to interact in a way so that we can really avoid, potentially deadly contact, right? Obviously, it doesn't work 100% of the time, but it does a lot to get us to a point where we're able to interact safely. I mentioned that as a gay person who has definitely had to navigate the question of HIV infection just in my life, right? This has been in my mind for a long time. And we know for things like HIV, if you want to 100% protect yourself from HIV, you can just avoid having sex and avoid taking injection drug use, right? And the fact of the matter is that telling people to abstain from sex and be celibate is very challenging. Okay, the vast majority of people just are not going to be able to do that for a variety of reasons. And so in public health, we have what are called harm reduction strategies. So this is the idea that people are going to engage in quote unquote risky behavior, but can we mitigate the risk in some way? So for HIV, that's things like making sure you wear a condom, and practice safe sex, reduce maybe the number of partners. It's also, getting tested. So for HIV, you can get tested for free, basically at any time. There are many clinics that will do that for you. And that access to testing allows us to catch infections early so that we can know what our status is before we expose others, right? And so these are all harm reduction strategies where we're saying we understand there is some risk always of this event happening, but we have systems in place to reduce that risk and to mitigate any potential negative outcomes that might happen if something happened where, for example, you were to get become HIV positive. And for something like an infectious disease, especially one that spreads by air and by talking, this is very much we are in a pool together, okay? And someone peeing in the pool somewhere else still affects everyone in the pool, maybe in slightly different ways, but it still eventually affects everyone, right? And this is, for example, a reason why that like flatten the curve idea while everyone, I think a lot of people really kind of supported the idea and kind of like, we're like, okay, we're going to do this. One of the major reasons why it failed is because as a nation, we didn't all do it together to the same extent. So some of us were doing it, some of us were not. And the people who were not were basically the people peeing in the pool and leaving themselves vulnerable to COVID infection. So that what we saw was places like New York City, which got hit hard, and they immediately put measures in so that cases went down. Well, then where did the cases go? They went elsewhere in the country where people were not taking these mitigation interventions seriously. So this is one of the challenges with infectious disease, especially ones that travel by air, is that you really need a collective approach towards mitigation, and any failure in that is going to allow the virus to spread and mean that we have to deal with it for a longer period of time. And I want to again highlight, even if you feel that you yourself are not going to be at risk for serious disease, if we just let things go, what's going to happen is we're going to overtax our healthcare system, because enough people, even with like a 1%, hospitalization rate, if we think about the millions of people in this country, that's still a lot of people that are going to end up in the hospital. And if they all go to the hospital at the same time, we can't treat them all at the same time. So these headlines were from end of December, early January, where at the end of December, Southern California, that region, there were a couple of weeks where there were 0 ICU beds available because they were almost all filled with COVID patients. And what that means is if you get into a car accident and need an ICU for treatment, you don't have a bed, right? So it's not just COVID, it's also everything else. So when we think about the healthcare system, the reason why we're trying to protect the healthcare system is because if we tax out the healthcare system, everything gets worse, not just COVID, right? And that's why we were thinking about this flatten the curve model, is because if we can keep the level of cases that are going to hospitals to a level that hospitals can manage, then we can keep things rolling, keep the economy rolling to an extent that we don't have to worry about losing all those ICU beds and other things. All right. I have about 5 minutes before we're going to turn it over to talking as a conversation. And so one new, obviously, one new mitigation strategy that we have now is vaccination. Now, to date, all of these other things that we've been doing have clearly not been enough, right? COVID is still here. We haven't really gotten rid of it. And there are a variety of reasons why it didn't necessarily work as well here as it did in, let's say, New Zealand or Australia, right? And we can talk about that. And really, at the end of the day, the US strategy from day one, from March of last year, was to rely on vaccination. That was the national strategy. And now the vaccines are here, right? And to be honest, we got really lucky because the vaccines we have are pretty awesome. Okay, and I say that as a virologist, as someone who studies vaccines. My professional opinion, and you can quote me on this, is that the vaccines we have are awesome. Okay. And some of this I had to update last night because we just got new data in the last just week on some of these, right? So what I mean by awesome is, for the 2 that have been approved for emergency use, which are the Pfizer and Moderna mRNA vaccines, we know from the clinical trials that they reduce severe disease, meaning if you're vaccinated and you do get COVID, you have a 90% reduction in the chance that you will have to be hospitalized if you get the Pfizer one. And basically they saw 100%. Now it's probably not 100%. It's probably a little bit closer to like 98 or whatever. But if you get these vaccines and you get COVID, it's going to be very unlikely that you're going to end up in the hospital. And actually it's also very likely that you won't even be symptomatic. In very recent data out of Israel, because Israel has used the Pfizer vaccine and has a very robust medical record system, they've been able to see after their really big push of vaccination that they were actually to show in this one paper that was just published that the rate of asymptomatic disease, meaning you don't get symptoms but you do get COVID, also dropped precipitously. And we're not entirely sure about the Moderna one yet. We don't really have good data yet. The clinical trial sort of suggested maybe 65%, but it wasn't really set up to answer that question. So that's why that's a question mark there, but still very good, right? The Johnson & Johnson vaccine they just had their presentations to the FDA yesterday. Tomorrow, the independent panel of experts that are reviewing the safety data will review the Johnson & Johnson clinical trial data. and make their recommendation. Based on what we've seen, it would be very unlikely that it's not going to be given authorization. So I expect Johnson & Johnson vaccine to be authorized for use next week. And we have lots of reasons to really be excited about this one. We know that they actually were set up to address these three questions very clearly, and they can show that there's, again, an 85% reduction in severe disease, a perhaps somewhat disappointing, but still really good 66% against symptomatic disease. And they did actually directly measure asymptomatic disease and saw there was a reduction there as well. And I just want to make a note with a double asterisk here that unlike the Moderna and Pfizer vaccines, the J&J vaccine trials did include regions where these other COVID variants are. And so their perceived reduction in efficacy is likely due to the fact that many of the patients have these variants that are a little bit better at dodging the immune system. And it's unclear actually right now to what extent in people the Pfizer and Moderna ones are also being reduced by those new variants. So even though that seems like a very big difference, honestly, from a public health standpoint, it's not that big of a difference. And there's a lot of reasons why the J&J vaccine is very exciting from a public health standpoint that I'm happy to go into more detail about. All right, so I'm going to breeze through this last slide so we can have a conversation. One last thing I just want to talk about this idea of civic duty of vaccination is we focus so much on technology that we forget all of the important public health points of distribution and logistics, right? And in the US, we've had a very decentralized strategy. The CDC provides guidance. The federal government, for the vaccines anyway, basically just provides the vaccines to states. And then it's up to states to figure it out. And states have been relying on local public health agencies for deploying them. And that means that depending on how resourced those agencies are, and how well there's communication infrastructure between the state and local level public health services, different regions, even within a state, and even cities within a given county can have very different experiences of how well things are rolling out because there isn't this central kind of federal government push for actual distribution. And in Philadelphia, we can talk about this in a little more detail. This is a little bit outside my actual expertise, but just some observations for Philadelphia. This is just pulled from the city of Philadelphia's public health database that I pulled last night. So we just see where doses are going in Philadelphia on the left. But what I find really important to think about on the right is an analysis of who has gotten the vaccine so far. And that's broken down by gender, with the left light blue column being females and the darker ones being males. And then they're kind of broken down by some racial categories. And what's important to keep in mind is the actual demographics of Philadelphia. So from census data that I pulled last night, the city of Philadelphia is about 42% African American, 42% white, and then a little bit, about 15% Hispanic, and 7% Asian, and a little bit less for everything else. But we look at who actually got vaccinated. Although 42% of Philadelphia are white, they have disproportionately been getting the vaccine at a higher rate. Whereas if we look at the African American population, it's much lower. And also same thing for same thing for Hispanics. Hispanics have not been getting vaccinated at the same rates either. And there are lots of reasons for this, right? As I mentioned, communities of color have had a long history of the medical establishment doing really horrific things to communities of color. So the Tuskegee trial, the history of gynecology, et cetera, et cetera, et cetera. So that's one component. The other component is, where are we setting up clinics for the vaccination? Are we actually going out into communities that actually need this the most? Or are we setting them up near University of Pennsylvania because that's where the hospital is? And where is the hospital? It's in University City, right? Like, who lives there, right? And you can think the same thing for Jefferson, et cetera, et cetera, et cetera. So this is just, I just want to throw that out there. It's just a thought-provoking kind of question there. And we've also seen in the Philadelphia Inquirer lots of reporting on some of the distributors have very problematic practices. I'm not going to spend too much time talking about Philly fighting COVID, but that was hopefully a big news item that you're familiar with. And if not, I suggest that you learn about it. Now, it's not all bad. We also have seen lots of amazing outreach and work from amazing organizations like Black Doctors Consortium. And this particular group, I'm just completely inspired by. They have, it's a group of Black doctors in Philadelphia who came together recognizing some of the disparities and hesitancy in the African-American community and communities of color and saying, we need to do something about this. So they've been going out, educating the community, providing free testing, and now providing vaccinations for folks. And so if you're interested in getting involved in helping to address some of the disparities in healthcare in this particular moment, this is just such a great organization to follow and to support. So I highly endorse them. And the vaccination matters because as people have been looking at the question of these new variants, as we vaccinate, depending how quickly we vaccinate, are we actually going to vaccinate enough people soon enough that the variants aren't going to completely take over? Right? Because these variants are more infectious, and that's why we're concerned about them. If we want to prevent a situation where these new variants are spreading like wildfire, we need to really up our vaccination campaign. And so that means we need to really kind of address why people might be hesitant or concerned about getting vaccinated, help them, answer their questions and give them resources that they may need to navigate that question, and then also just increase access and availability. So again, there are many things that we can do to help make the situation better to get COVID finally under control. Vaccination is a key component of it. And any little thing that we do makes a big difference. I don't know why this paused here. Here we go. So, this is just a model of like how COVID spreads exponentially. And because it spreads exponentially, every small decision we make actually can have a profound influence on the outcome. So your actions do matter. So I'm going to end this portion by just saying, is vaccination a civic duty? Meaning, is it something we should be doing for our community? I'm going to just say yes, right? I say vaccination protects the community as well as the individual based on just how vaccines work. The available vaccines we have are safe and they are very effective. So we got lucky there. And they are going to be really what get us to herd immunity in a safe manner. That's not going to involve, we lost over 500,000 people at least to COVID already. So let's stop having people died for the sake of trying to get to herd immunity. That being said, let's just remember the vaccine hesitancy is real. It's informed by real fears and values that people have and perhaps misinformation. And we should be approaching this question and this effort for vaccination with empathy and understanding of others. And we must be considering who's actually most vulnerable in our community and what can we do to support them better. So with that, perfect. We're going to stop here so I can see your faces again. I'm going to take a deep breath. I'm going to look at the chat, and then I'm going to invite you to ask questions. What do you want to talk about? What are your concerns? What do you want to learn more about? Feel free to post those in the chat, or if you want to use the raise hand feature, I can call on you. Again, the way you do that is you click on the participants button in Zoom, and there should be a panel underneath the list of participants, and it should be a raise hand button there. So feel free to do that, and please let me know what your questions are.
I don't know if you saw in the chat that there was a question about, yeah, you're nodding.
Yes, I'm looking at that right now. Okay, so I believe, Diana, that you were asking about, let me just make sure I know which chart you were talking about because I moved on. I believe you're asking about the map. Was it this one, Diana?
That's correct. I was asking about the Philadelphia map because, and here's my demographic concern.
Yes.
The neighborhoods that I'm going to concentrate northwest and northeast. Okay. So the neighborhoods that are darkest blue, Chestnut Hill, Mount Airy, Roxborough, Manayunk, looks like East Falls. You have, at least in that area in the Northwest, I live there, that's how I know this, there is a fairly decent concentration of nursing homes and other long-term care facilities, and they were distributed vaccines separately. And obviously, those elderly in compromised health states were priorities for vaccination. The two dark blue areas, Northeast and Northwest, are also areas with zip codes that have the highest number of firefighters and police as residents. So, which I know skews the data somewhat. But I think that a map like that needs to kind of be looked at in the context of not just straight race and ethnic, but who are these people? We've got to look at it across more strata of data.
Yeah, I love what you're adding to the conversation, Diana, because that is a very important part of the conversation. I really focused in my slides here as I kind of zip through them on those who are most vulnerable to serious disease, but that's not the whole story, as you're saying, right? There is, in addition, populations of people that we want to give access to the vaccine first because they're most at risk of just seeing other people, right? So our firefighters, our police officers, and so our frontline workers, right? And so, there are slightly different reasons why both of those are important, but that's also why they were at the kind of the front of the line. So I also really thank you for kind of revealing some of the explanations of why those particular regions are darker. I will say that this is not separated by anything more than just how many people were vaccinated. So based on what you just said, I think it actually makes a lot of sense why those regions are darker, because those first responders and those long-term care facilities were definitely the ones to get access to the vaccine sooner. And that's a question that we need to keep in our minds as we're also considering, other communities who also don't have access, which are perhaps communities of color. And so it's not, I always say it's not this or that, but it's this and that, right? For situations like this. So what's the best way that we can add what you're bringing to the table, Diana, to also this other just observation that communities of color are not getting vaccinated? Now, I've already mentioned also, I just want to again remind folks that because of the history of medical malpractice with communities of color, there's a lot of hesitancy. So it's not always a question of access to vaccines, but also utilizing the vaccine too. And so that's why groups like the Black Doctors Consortium are really working on helping to educate and help talk to these communities so that they will actually make use of what's available to them. So it's definitely a lot of those extra layers that you're adding. So to answer your question very briefly, it's just everyone. And I think that you added actually a lot of perspective onto why those particular regions might be, particularly concentrated. So thank you for adding that. What are some other questions or just things that people want to add to the conversation?
I have a question for you, Jason.
Yeah.
So, and thank you so much. This presentation was fabulous. So I just want to say that.
Mm-hmm.
So I have a 5-year-old daughter, and obviously kids under 16 are not getting the vaccine. So I was wondering, number one, why is that? And number two, when we talk about everyone being vaccinated, does that include children?
Thank you so much for bringing that question up. So there are a couple reasons for that. And I'm just going to say, Natalie, I see your hand up too. So you're going to be after Angela. Thanks. The primary reason that we're not giving it to children yet is because the clinical trials, by and large, were set up just for adults, as defined as 18 or older. I believe the Moderna one also has a small cohort of people who were 16 and older. And there were a couple of reasons why children were not included. Generally, children are not going to be included in clinical trials at the start because they're just more vulnerable. We don't want to be testing new therapies on children, so we're going to do it on adults who are more able to provide consent. One reason why you might change that perspective is if the disease seems to be disproportionately affecting children, or if we're really particularly concerned about children. And basically, within the first couple of months, it seemed pretty clear who was going to the hospital, who was having serious disease from COVID. It was generally adults and generally older adults. So when the clinical trials were set up, they decided that it wasn't really worth the risk of potentially harming children who can't really give consent. Their parents give assent for them, right? It just didn't seem it was worth, quote unquote, worth it at that stage. And so because we don't have data to know exactly for sure, that's why at this point we're going to kind of rely on the data that we have. That being said, we are interested in vaccinating children, and right now there are efforts to start enrolling in clinical trials children for this. I think AstraZeneca is doing this. I think Pfizer started. I lost track of some of those trials. So we're starting to ask that question. When people are saying everyone's vaccinated, I think at this point, what they really mean is all the adults. I don't think, like, we're not going to get all the children vaccinated and all the adults by the end of this year. That's not going to happen. But I think they're focusing on the adults. And I feel pretty confident based on the data that we have that I think that's still going to provide a safe environment for children, right? I think that, we are seeing in schools, young kids are getting COVID and getting sick. They are generally not being hospitalized, but they are giving it to other people who might be more at risk. So if we can get the people at risk, like adults, vaccinated, then even if children might still be able to get COVID, they're going to be relatively okay, and no one else is really going to have serious disease. It's kind of the thought behind that. So I think I covered everything I was going to say about that. Do you have any follow-up questions, Angela? Okay.
That was great. Thank you.
Natalie, go ahead.
Yeah, I'm wondering if you can speak to like what defines a strain versus a variation, and how is that like impacting like the vaccination strategy, and how should we be thinking about those as we think about getting vaccines? Okay,
so how much virology do I want to go in? So to be honest, the question of like, is this a new strain or not? So the experts in that particular virus's biology generally come up with parameters to determine how many genetic differences do you need for it to count as a different strain, right? Versus a variance, right? And to be honest, for the general public, you don't really need to know, like, it doesn't really matter whether we call it a variant or a strain. What matters is what's the biology and what's the health outcome, right? And so the coronavirus is always going to be making mutations. Some of them are going to not do anything. Some of them are going to be bad, and therefore they're going to disappear over time. The ones that we care about are the ones that make the disease more serious, or make it spread better, or make it somehow be a harder public health threat, right? And so I think that we've been saying variants at this point because by and large, the viruses are mostly the same. It's a very small change in one particular protein, the spike protein, that we're really, actually other proteins as well, that we are concerned about. And so from like a virology standpoint, we're going to use the word strain. But from a public health standpoint, we are concerned because they spread so quickly. So again, the reason why we're really concerned about these new strains coming out of the US, the UK, South Africa, et cetera, is because of, let's see if I can get to that slide really quick, this slide, right? If you have a more infectious strain, it spreads more quickly, and therefore your particular rate of vaccination may actually be too slow to actually vaccinate people before they actually see the virus, right? So when we see, in this case, a situation where we have strains that are more infectious, what that should inform us is we need to vaccinate faster, because if we vaccinate faster, we close all routes for the viruses to kind of find new hosts. Now, that being said, people are also concerned about, well, also it seems like the vaccines might be slightly less effective. So by and large, I would say I'm not too worried about that, and I think most experts aren't, because when we measure the immune response to like the Moderna and Pfizer vaccines, the response is super awesome. Like the level of antibodies, the level of T cell response, et cetera, super awesome. When we look at the variants, it goes from super awesome to awesome. So it's still very good. When you have on the order of like, 10,000 or, 100,000, dilutions that you need for these antibodies, and there's like a twofold difference, that's like, it doesn't really make a big difference at that point. That being said, I'm also actually very encouraged by the design of these vaccines, because mRNA vaccines can be adapted very quickly. We can change the sequence of the mRNA portion of the vaccine to match the new variants. And the FDA in the last week just clarified that for the mRNA vaccines, those manufacturers will not have to do completely new clinical trials for the new variants. Instead, they can just take, okay, we see the Brazil strain, let's change the formulation of the mRNA a little bit. We're going to do a small safety trial to make sure it's still safe and still makes the immune response. If we can show that, then FDA is going to give us clearance to put it on the market. So similar to flu, how we're constantly changing the flu vaccine in response, we're already putting into place a system for that. So that's kind of how I think about the strains that are cropping up. The biggest thing is, if you want to prevent new strains from happening, you need to prevent infections. And so that's why vaccinating and really clamping down on spreading infection is really the best strategy for dealing with strains like these. So none of them have really caused much more serious disease. There's been some reports that some of them are maybe a little bit more serious, but it's not a dramatic difference. So I think, again, more vaccination, more vaccination, more vaccination is my answer to that. I see Tracy has her hand up.
Hi, thank you. This has been an amazing talk. So thank you very
thank
much
you
for that. I probably have 50 questions, but I'll limit it
Great.
to one.
Okay.
So that other folks have a chance to ask. So there has been conversations, and you have in your charts, like the faster we can get vaccinated, the better off we are from a herd mentality standpoint. So I've heard things along the way. I thought it was even attributed to Dr. Fauci saying, like, so maybe we shouldn't be doing 2 shots. Like maybe we should get everybody with a shot, so that more people are vaccinated, even if the efficacy isn't as strong. And so help me understand pros and cons of that thinking, if it is even a possibility given the testing that was done with the vaccines to begin with.
Yes. Fantastic question. This is one of those things where if you had asked me that like literally a week ago, I would have a very different answer. And that's because we're getting new data all the time. So to fully answer that question, I'll give a little bit of historical kind of answer to that, and then we'll talk about the more updated one. This question really was jump-started when the UK, when they started their vaccination, thinking along the same lines, we're like, you know what, maybe we should delay the second dose by as much as 2 months so that we can get at least some protection sooner, right? And there's a lot of controversy. I can tell you many you could find plenty of scientists on both sides of the column. And it kind of depended on, do I care more about the public health, or do I care to make sure that this particular individual gets the best protection? And depending on who you're talking to, that actually might be a different calculus. So for example, if I'm worried about my 85-year-old grandmother who lives by herself, I like, don't screw up the schedule, give her both doses in the way that we know she gets the maximum protection. If I care about, so she lives in Puerto Rico. So if I care about the island of Puerto Rico, which is not just my grandmother, but many others, right? Well, maybe delaying makes sense. So it's a tricky question, right? And I think, and I think many immunologists and virologists are like, we have the data that says it definitely works here. I'm really concerned about changing the schedule because I'm not sure what's going to happen, right? And so that's why you see different answers in different places. It kind of depends on what your values and priorities are. Now, fortunately, actually, we got very exciting news in the last week. And the exciting news, which again was from some work that was done in Israel, is in Israel, they actually did a study as people were getting vaccinated to kind of test between doses what was going on. And we know for the Pfizer vaccine, and actually, let me go back to, actually, I didn't put that on the slide. Never mind. From the Pfizer vaccine, we now have very good data that shows that after a single, 2 weeks after a single dose, we see a 90% reduction in symptomatic disease. They had enough numbers to now actually come down and say, this is what we think is happening, right? That's super awesome news, because that means actually, okay, we still want 2 doses to get really the best response, but I think people are actually going to be very well protected if they just get the 1 dose. And so that, coupled with the other finding that, again, because of some work that Israel did, that these vaccines seem to actually be preventing asymptomatic disease as well, they're also potentially preventing spread. So I think that because of the new data that we're seeing just in the last week, I don't know exactly what's going to happen, but I could see an argument for saying, I think it's okay actually to maybe delay the second dose for some people. I think it's going to be okay. So I'm not sure what's going to happen with that. But I think if people do decide, let's delay the second dose, I'm feeling more and more confident that it's still going to be a good strategy to delay a second dose if we decide to do that. Again, depending on the like if it was me, 1 dose, you want to delay the second, fine, because I'm a healthy 35-year-old or whatever, right? But my grandmother's like, no, let's give her 2 within 2 weeks, just so we know for sure. The other kind of calculus there is the J&J vaccine. The J&J vaccine, all that data is based on a single dose. And also that vaccine does not require freezing. It can just be done in the fridge. And so because of that, places like CVS and other pharmacies and your doctor's offices are going to be much better equipped to deliver these vaccines. So even if we decide, you know what, the Moderna and Pfizer ones, let's not play around with the second dose too much. There's this other new vaccine that will hopefully be approved next week that's only a single dose. And so for folks that are relatively healthy and don't really have serious risk of disease, I anticipate we're going to really focus on giving them the J&J vaccine to kind of increase the numbers and really keep the Moderna and Pfizer ones for the folks who are most vulnerable. So those are our first responders, those are our elderly, those are people with other health diseases. So that's kind of how I'm thinking about it and how I think other people are thinking about it.
Great, thank you.
You're welcome. Yeah,
Appreciate
honestly,
the
I'm so
ethical-
excited. What's that?
I appreciate also the ethical conversation that you framed it, because that was quite interesting.
Yeah. And that's why I tried in the beginning to have us start thinking about who else is in the room together, because I think where a lot of people get very angry and anxious about what they're seeing in the news is because they're looking at it from their perspective and from their lived experience. And it's so hard for us to remember other lived experiences. And this is why I really appreciate working with a public health professional and a communication professional, because they are much better at looking at things from that perspective. And I've learned so much to kind of think things, even just outside of a scientist's perspective, like, as a scientist, like, no, do what the protocol says. And it's like, well, maybe there are some reasons why we might have to kind of push it, right? So very good. I think we have time for maybe one more question. I know there's another session at 4, right? So I don't want to keep people here too long. So let's maybe do one more. Anyone have any last questions?
I know I have a question, but I'll pause to see if anyone else wants to jump in.
All right, let's wait 30 seconds for one more question, and then Emily can get it. This is what I do in class, so you're gonna have to bear with me. All right, 30 seconds. Go. Last question.
All right, I'm going to throw a fly in the ointment. It's Diana.
Thank you, Diana. Please do so.
In 1905, the U.S. Supreme Court held that states and localities could mandate vaccination by law. In that case, it was a smallpox outbreak in Cambridge, Massachusetts. Do you think it is viable for states or localities, depending on their political leanings, to try to enforce vaccination for the public good by law, but just as we do with compulsory vaccination of children for school? I'm just going to throw that fly out in the ointment.
I love that question, Diana, and thank you for bringing that up.
And I'm going to mute myself now.
Okay. Yeah. That is such a complex question, and my answer to you is not going to. I want to make sure that I'm very clearly going to take off my expertise hat, because I'm a scientist, not a politician, and not a policy person. So, and I could see pros and cons for both. I think that anything that's compulsory is always going to cause backlash and hard feelings, and you know, you're actually going to incite people fighting against it a little bit more. Is it worth it? Now, I want to be clear, as someone who is a scientist who studies viruses and understands how vaccines work, I am all for give me all the shots, give everyone all the shots, please get all the shots, right? Outside of some very specific medical situations. And so for me, a compulsory vaccination policy makes sense to me, because that's how you best protect everyone. From the stance of public health, it makes sense. We already have a model for that. So like, if it was me, I'd be like, yes. But I think that at the same time, if our strategy is to, even for compulsory vaccination, we always provide an out for people, right? There's objections that people can raise and file, and some people maybe abuse those in particular ways, but a compulsory vaccination is very rarely actually compulsory. Like, do you actually vaccinate everyone? There's always going to be people who don't vaccinate. And so there's a question of like, well, they're not going to vaccinate anyway, so let's just make it compulsory because we're never going to convince those people. I could see that argument. On the other side, I can say, maybe is the strategy rather to address why people aren't getting vaccinated anyway and get enough buy-in that they're going to do it on their own. And so I didn't really answer your question, Diana, and that might be frustrating, but that's just because I think this is a very complex question and I don't really feel very well equipped to really come down, yes, we should do this or not. I am really big on vaccination. I think I made that pretty clear in my presentation. So I would definitely support that. But I think there's a lot of political concerns and economic and even social ones that are tied up with that. And I don't really know what the best answer is. And I would say at the university level, right? I work at a university. I'm definitely being asked to weigh in on policy decisions at the university. We have mandatory vaccination for residential students on campus. For other vaccines, right? You need to get your measles shot and your things like that. And so the question is like, do we mandate it? And for a variety of reasons, I'm like, I'm not really sure that it's going to be worth the possible either backlash or just the negative outcomes for at least at the university level, especially for vaccines that these are technically vaccines that have emergency use authorization. They are still very new. It's a very different question to say, I'm going to mandate that you get the measles vaccine because we have decades of research on that. We don't have decades of research on these vaccines. And so I think that there could be an argument for like, does it really make sense to be mandating a vaccine that just came on the market just now? Even though we're really sure they're safe, it is kind of early, right? So these are just some of the questions in my mind as I'm grappling with this question. And I'm sure there are other concerns that you might even bring up, Diana, but that's kind of what, this is how I'm struggling with this question.